The drugs in this chapter are divided into two dissimilar groups. The neuromuscular blocking drugs, which act at a skeletal myoneural junction, are used to produce muscle paralysis to facilitate surgery or assisted ventilation. The spasmolytic drugs, most of which act in the CNS, are used to reduce abnormally elevated tone caused by neurologic or muscle end plate disease.
So here are the terms that you need to know in this report. Depolarizing blockade. Neuromuscular paralysis that results from persistent depolarization of the end plate. Next is desensitization, a phase of blockade by a depolarizing blocker during which the end plate repolarizes but is less than normally responsive to agonists. Next is malignant hyperthermia. Hyperthermia that results from massive release of calcium from the sarcoplasmic reticulum, leading to uncontrolled contraction and stimulation of metabolism in skeletal muscle. Next, non-depolarizing blockade. Neuromuscular paralysis results from pharmacologic antagonism at the acetylcholine receptor of the end plate. Next, spasmolytic, a drug that reduces abnormally elevated muscle tone without paralysis. Lastly, stabilizing blockade, synonym for non-polarizing blockade. Skeletal muscle contraction is evoked by nicotinic cholinergic transmission process. Blockade of transmission at the end plate is clinically useful in producing muscle relaxation, a requirement for surgical relaxation, tracheal intubation, and control of ventilation. The neuromuscular blockers are quaternary amines structurally related to acetylcholine. Most are antagonists, and the prototype is tubercularine. One neuromuscular blocker used clinically, succinylcholine, is an agonist at the nicotinic end plate receptor. Pharmacokinetics of the drug. All agents are given parenterally. They are highly polarized and do not cross the blood-brain barrier. Drugs that are metabolized by plasma cholinesterase or eliminated in the bile have shorter durations of actions, about 10 to 20 minutes, than those eliminated by the kidney, which usually have durations of action of less than 35 minutes. In addition to hepatic metabolism, atracurium clearance involves rapid spontaneous breakdown to form luadenosine and other products. At high blood levels, luadenosine may cause seizures. Cistracurium, a stereoisomer of atracurium, is also inactivated spontaneously but forms less luadenosine and currently is one of the most commonly used muscle relaxants in clinical practice. So here is the mechanism of action of the drug. The first figure at the top, ACH, the normal agonist, opens the sodium channel. Next is the bottom left, which non-depolarizing blockers bind to the receptors to prevent opening of the channel. Bottom right, succinylcholine causes initial depolarization, which is called fasciculation, and then persistent depolarization of the channel, which leads to muscle relaxation. Non-depolarizing drugs prevent the action of ACH at the skeletal muscle end plate. They act as surmountable blockers. That is, the blockade can be overcome by increasing the amount of agonist, which is the ACH in the synaptic cleft. They behave as though they compete with ACH at the receptor, and their effect is reversed by cholinesterase inhibitors. Some drug in this group may also act directly to plug the ion channel operated by the ACH receptor. Post-tetanic potentiation is preserved in the presence of these agents, but tension during the tetanus fades rapidly. Large muscles, example are abdominal and diaphragm, are more resistant to neuromuscular blockade, but they recover more rapidly than smaller muscles. Of the available non-depolarizing drugs, ricuronium has the most rapid onset time. Phase 1 block, depolarizing. Succinylcholine is the only clinically useful depolarizing blocking drug. Its neuromuscular effects are like those of acetylcholine, except that succinylcholine produces a longer effect at the myoneural junction. It reacts with the nicotinic receptor to open the channel and cause depolarization of the motor end plate, and this in turn to spread to the adjacent membranes, causing transient construction of muscle motor units. Data from single-channel recordings indicate that depolarizing blockers can enter the channel to produce a prolonged flickering of the ion conductance, Because succinylcholine is not metabolized effectively at the synapse, the depolarized membranes remain depolarized and unresponsive to subsequent impulses. Next is phase 2 block, which is desensitizing. With prolonged exposure to succinylcholine, the initial end plate depolarization decreases and the membrane becomes repolarized. Despite the repolarization, the membrane cannot easily be depolarized again because it is desensitized. The mechanism for this desensitizing phase is unclear, but some evidence indicate that channel block may become more important than agonist action at the receptor in phase 2 of succinylcholine's neuromuscular blocking action. Pharmacokinetics of succinylcholine. Succinylcholine is composed of two ACH molecules linked end-to-end. Succinylcholine is metabolized by cholinesterase in the liver and plasma. It has a duration of action of only a few minutes if given as a single dose. Blockade may be prolonged in patients with genetic variants of plasma cholinesterase that metabolize succinylcholine very slowly. Such variants cholinesterase are resistant to the inhibitory action of dibukane. Succinylcholine is not rapidly hydrolyzed by acetylcholinesterase. Next is the mechanism of action of succinylcholine. Succinylcholine acts like a nicotinic agonist and depolarizes the neuromuscular end plate. The initial depolarization is often accompanied by twitching and fasciculations. Because tension cannot be maintained in skeletal muscle without periodic repolarization and depolarization of the end plate, continuous depolarization results in muscle relaxation and paralysis. Succinylcholine may also be plug and end plate channels. When given by continuous infusion, the effect of succinylcholine changes from continuous depolarization, which is phase 1, to gradually repolarization with resistance to depolarization, which is phase 2. Next is reversal of blockade. The action of non-depolarizing blockers is readily reversed by increasing the concentration of normal transmitter at the receptors. This is best accomplished by administration of cholinesterase inhibitors such as neostigmine and pyridostigmine. In contrast, the paralysis produced by the depolarizing blocker succinylcholine is increased by cholinesterase inhibitors during phase 1. During phase 2, the block produced by succinylcholine is usually reversible by cholinesterase inhibitors.
Toxicity. The action of full doses of neuromuscular blockers leads directly to respiratory paralysis. If mechanical ventilation is not provided, the patient will asphyxiate. Autonomic effects and histamine release. Autonomic ganglia are stimulated by succinylcholine and weakly blocked by tubocurarine. Succinylcholine activates cardiac muscarinic receptors, whereas pancuronium is a moderate blocking agent and causes tachycardia. Tubocurarine and mivacurium are the most likely of these agents to cause histamine release, but it may also occur to a slight extent with atracurium and succinylcholine. Vecuronium and several newer non-depolarizing drugs have no significant effects on autonomic functions or histamine release. Here are the specific effects of succinylcholine. Muscle pain is a common post-operative complaint and muscle damage may occur. Succinylcholine may cause hyperkalemia, especially in patients with burn, spinal cord injury, peripheral nerve dysfunction, or muscular dystrophy. Increases in intragastric pressure caused by fasciculations may promote regurgitation with possible aspirations of gastric contents. Drug interactions. Inhaled anesthetics, especially isoflurane, strongly potentiate and prolong neuromuscular blockade. A rare interaction of succinylcholine and tubocurarine with inhaled anesthetics can result in malignant hyperthermia. A very early sign of this potentially life-threatening condition is contraction of the jaw muscles, or also called trismus. Aminoglycoside antibiotics and antiarrhythmic drugs may potentiate and prolong the relaxant action of neuromuscular blockers to a lesser degree. Effects of aging and diseases. Older patients who is 75 years old and above and those with myasthenia gravis are more sensitive to the actions of the non-depolarizing blockers. Doses should be reduced in these patients. Conversely, Patients with severe burns or who suffer from upper motor neuron disease are less responsive to these agents. Next is spasmolytic drugs. Certain chronic diseases of the CNS such as cerebral palsy, multiple sclerosis, and stroke are associated with abnormally high reflex activity in the neuronal pathways that control skeletal muscle. Bladder control and anal sphincter control are also affected in most cases and may require autonomic drugs for management. In other circumstances, acute injury or inflammation of muscle leads to spasm and pain. Such temporary spasm can sometimes be reduced with appropriate drug therapy. The goal of spasmolytic therapy in both chronic and acute conditions is reduction of excessive skeletal muscle tone without reduction of strength. Reduced spasm results in reduction of pain and improved mobility. Drugs for chronic spasm. The spasmolytic drugs do not resemble ACH in structure or effect. They act in the CNS and in one case in the skeletal muscle cell rather than at the neuromuscular end plate. The spasmolytic drugs used in treatment of the chronic conditions mentioned previously include diazepam, a benzodiazepine, baclofen, an aminobutyric acid or GABA agonist, tizanidine, a congener of clonidine, and dantrolene, an agent that acts on the sarcoplasmic reticulum of skeletal muscle. These agents are usually administered by the oral route. Refractory cases may respond to chronic intrathecal administration of baclofen. Botulinum toxin injected into selected muscles can reduce pain caused by severe spasm and also has application for ophthalmic purposes and in more generalized spastic disorders such as cerebral palsy. Gabapentin and pregabalin anti-seizure drugs have been shown to be effective spasmolytics in patients with multiple sclerosis.
Mechanism of action. The spasmolytic drugs act by several mechanisms. 3 of the drugs, baclofen, diazepam, and tizanidine, act in the spinal cord. Baclofen acts as a GABA-B agonist at both presynaptic and postsynaptic receptors, causing membrane hyperpolarization. Presynaptically, baclofen, by reducing calcium influx, decreases the release of excitatory transmitter glutamic acid. As postsynaptic receptors, baclofen facilitates the inhibitory action of GABA. Diazepam facilitates GABA-mediated inhibition via its interaction with GABA-A receptors. Tizanidine, an imidazoline related to clonidine with significant 2 agonist activity, reinforces presynaptic inhibition in the spinal cord. All 3 drugs reduce the tonic output of the primary spinal. Dantrolene acts in the skeletal muscle cell to reduce the release of activator calcium from the sarcoplasmic reticulum via interaction with the ryanodine receptor RYR1 channel. Cardiac muscles and smooth muscles are minimally depressed. Dantrolene is also effective in the treatment of malignant hyperthermia, a disorder characterized by massive calcium release from the sarcoplasmic reticulum of skeletal muscle. Though rare, malignant hyperthermia can be triggered by general anesthesia protocols that include succinylcholine or tuberculin. In this emergency condition, dantrolene is given intravenously to block calcium release. Next is we're going to talk about toxicity of the drug. The sedation produced by diazepam is significant but milder than that produced by other sedative hypnotic drugs at doses that induce equivalent muscle relaxation. First drug is baclofen. Baclofen causes somewhat less sedation than diazepam, and tolerance occurs with chronic use. Withdrawal should be accomplished slowly. Next drug is tizanidine. Tizanidine may cause asthenia, drowsiness, dry mouth, and hypotension. Lastly, dantrolene. Dantrolene causes significant muscle weakness but less sedation than either diazepam or baclofen.